Okay. Okay, so let's go ahead and get started. Okay. So for today's agenda, we're going to be talking about a few things here, and we'll go through each element. So the first half will be about the actual circles, introducing the three circles, what members do, time and compensation. And then the latter half will be focused primarily on co-chairs, on the roles, and then from there, application and interview process. We'll also go over some key dates as well, and then a Q&A. Okay, so most of you or some of you may know who we are. So we're Diabetes Action Canada. We're a pan-Canadian research network bringing patients, caregivers, healthcare experts, and researchers together to address diabetes health concerns through collaborative research. So our research efforts prioritize, equity, diversity, inclusion to enhance healthcare for all, and it's also funded through the Strategy for Patient-Oriented Research, which is SPORE, and it's a program at the CHR and other partners. So that tells you a little bit about us. We plan, execute, and evaluate work. We advance patient-oriented research, innovate with patient engagement, knowledge sharing, and digital health, and also strengthen diabetes care systems through interdisciplinary collaboration. So that will be what the circles is focused on. And this is just a little slide to provide some more information on the patient-oriented research with an EDI lens and knowledge mobilization as well. Okay, so what are the patient partner circles? So, patient partner circles are a paid advisory group for people with lived and loved experience of diabetes. So, lived and loved basically means you either live with diabetes yourself or you are a caregiver, a family member with someone who does have diabetes. As a patient partner, you will help shape Diabetes Action Canada's work through reviewing research ideas, resources, plain language summaries, identifying topics that matter to people affected by diabetes, and advising DAC on how we recruit, welcome, support, and compensate patient partners. So, why the circles matter? Well, the circles help make sure diabetes research, resources, communications, training, and patient engagement are shaped by people most affected by diabetes. And it really shapes DAC's work and kind of holds us accountable to make sure we are hitting what our target is, which is to help people with diabetes and holding us accountable. Circle members help DAC understand what matters to people affected by diabetes and how our work can be most useful, accessible, respectful, and also relevant. So, what is a patient partner? Patient partner is basically someone who engages with DAC circles and brings together people across Canada with lived and loved experience or diabetes to help shape our work. So, patient partners, as I mentioned, includes people living with diabetes, family members, caregivers, and loved ones of people living with diabetes. And now we'll get into the three individual patient partners and patient circles. So, the first one is Collective Patient Circle. Second is Indigenous Patient Circle, and third is Francophone Patient Circle. Each circle has up to 15 members and also requires two co-chairs. So the first one on the list is the Collective Patient Circle. This is a national patient circle for patient partners from across Canada with different diabetes experiences, backgrounds, regions, and perspectives. This circle is co-run by Lindsay. She's in our meeting and she's the Director of Patient Engagement at DAC. The Indigenous Patient Circle is a dedicated space for Indigenous patient partners, including First Nations, Inuit, Métis, and other Indigenous people living in Canada who bring lived and loved experience of diabetes. This circle is co-run with the Indigenous Diabetes Health Circle. And the Francophone Patient Circle is a dedicated space for Francophone patient partners living in Canada who bring lived or loved experience of diabetes. This circle helps strengthen French language engagement, resources, communications, and research partnerships. And this circle is co-run by Lori, a Francophone engagement coordinator at DAC. She's also in this call as well. So this is a little bit about what do each circle members do. So circle activities are a bit mix of everything. So you review sources, you give feedback on research and ideas, but you also might help make diabetes research easier to understand, again, using that plain language. You can suggest themes for blogs, webinars, and tools and communications, help DAC improve patient partner process overall, and also support town halls. The circles are advisory groups. So this means that members provide guidance and recommendations, but they are not held responsible for making final DAC decisions and are not necessarily responsible for DAC. So you're not expected to represent an entire community. You do not need to have research experience, and you are not responsible for final DAC decisions. Who can apply? To qualify, you must meet the following criteria. So you must live in Canada, you must have lived or loved experience of diabetes, you should be interested in respectful and collaborative discussions, and you want to help shape DAC's research and policy work. For time commitments, most meetings online are usually 60 to 90 minutes, and circles meet 6 to 8 times a year. Mostly our meetings are held online. When they can be held in person, it's an option, but typically, almost always, they are held on Zoom. So if you're worried about accessibility or participation, we have you covered. So agendas are always given in advance. There are plain language materials. Documents are always accessible with flexible camera use. So if you're having a not so great day and you don't want to have your camera on, that's not a problem at all. We are always happy to hear different ways to participate and options to share inputs outside of meetings when possible. Compensation. So Circle members receive 95 Canadian dollars per Circle meeting. Co-chairs receive 195 Canadian dollars per Circle meeting. If a member cannot attend for an exceptional reason, but reviews materials and sends comments, they still receive $50. Okay, so now we're going to get into the co-chair roles. So what are the roles? Co-chairs help guide the work of the circles, which support Diabetes Action Canada staff, which includes Lori, Lindsay, and myself. Each circle will have two co-chairs. One co-chair position in each circle is reserved for a youth member. So the youth co-chair position means someone under 31 or younger. The youth co-chair has the same authority and voice and decision-making role as a co-chair. It's just reserved for someone 31 and younger. Co-chair responsibilities mean help set agendas, support inclusive discussions, summarize key points, identify priorities, welcome new members, and support youth leadership. Basically, they kind of take the reins in meetings just to make sure you stay on agenda, stay in kind of the target of that conversation, and also to help maybe facilitate any questions. If there's something you don't know, you can always refer to Lindsay or myself or Lori, but usually you'd be someone they would ask as well. Okay, and as we mentioned, co-chair compensation, co-chairs receive 195 per circle meeting. This is because you're doing a little bit more work. So this includes preparation, agenda planning, meeting leadership, and follow-up connected to the role. So you'll be in conversation with Lindsay and myself and Lori as well. Okay, so the application timeline. So applications open July 27th, 2026, and they close on August 12th, 2026. Today's the day of the webinars. These webinars are recorded and they will also be online later today. So if you have a question or you want to review everything, you can go ahead and refer back to this video. It'll be available on our YouTube, and we'll make sure to post a link on our social medias so that you can easily access it. After you apply, applications will be reviewed. Shortlisted applicants will be invited to a group interview, and then from there, successful applicants will be invited to an onboarding meeting. So here we have the group interview schedule. So the Indigenous group interview will be on September 9th, 4 to 6 p.m. Eastern. Collective group interview 1 is September 9th, 6 to 8 p.m. Eastern. Francophone interview is September 10th to 4 to 6 p.m. Eastern. And collective group interview 2 is September 10th, 6 to 8 p.m. Eastern. So a little bit more information about the group interviews. Group interviews are part of the selection process. They are not compensated. They help us understand how applicants work with others in group settings, so we get a good sense of how everyone will interact with each other prior to taking you on in the official role. So, what we are looking for in the interviews, how people interact with each other, how they step forward and step back, how they listen, how they respond to different ideas, how they make space for others, and how they contribute to respectful discussion. So, we just want to make sure that you're a team player and are willing to listen and be heard. So, onboarding for successful applicants, English onboarding call would be September 22nd from 4 to 5:30 p.m. Eastern. French onboarding would be from September 22nd, 6 to 7:30 p.m. Eastern. The first co-chair meeting this will be the first introductory meeting with the steering committee on October 5th, 2026. So here are some tips for applying. Use your own voice. There is no perfect answer. Tell us what you care about and why, what experience you bring, and how you want to use that experience to pay it forward, and what you would like to help shape. And are there any questions?
Thanks so much, Mackenzie. There's one question in the chat about town halls. I'll ask you to stop sharing just so folks can see our faces while we answer. So there was a question in the chat about what does supporting with town halls mean and what does that look like? We've had a request from our patient partner communities and like our old circles as well. I see Matt's on here about how can we share more research with the wider patient community, and B, get more ideas because we also have researchers who don't know what to study sometimes and they kind of pull something out of a hat versus we already like we have questions as people with diabetes and family members that we would like answered. So the town halls are something that we want to be starting as an official process for all three circles later this year. And each circle will get to run their version of what's important to them of this town hall to give some updates on what has DAC researched and like what have we found in the last 3, 6 months. What questions do patient partners have, but also as a method of like talking to each other and meeting each other. It's great in one way that we have virtual meetings because it increases accessibility. People can be everywhere from Castlegar, BC to Charlottetown, PEI. And it's great that we do that, but we also have heard folks say that they want more time to chat with each other and meet other people with diabetes. So that's the idea behind the town halls, but we'll co-design exactly what that looks like with our patient circles. I also see that there's a question about how many meetings. It's 6 to 8 meetings per year. Yeah. Does anybody else have any other questions about the circles or the application process? Awesome. Okay. Um, I see that there's a form online, but it wouldn't let me go very far because I didn't want to complete it before this meeting. Very fair. The form will not ask you for your resume. It's all just very short answer questions. That's a very deliberate decision that we co-designed with folks with diabetes to make it accessible. We're not evaluating career history or academic history. Really, what we're looking for is tell us about you and your experiences, and how do you want to use those experiences to make research more accessible, make it better for the community, as well as being heard yourself? I think one really important distinction that I would like to share with everyone here, but also for the recording, we have focus group opportunities that go out often to our mail list that have quite like a question about a specific topic, and a researcher wants to hear your ideas and experiences around that. The patient circles are not that. The patient circles are leadership bodies, which means that absolutely, are we looking for folks that have lived experience of diabetes and other stuff that comes with diabetes? Yes. But for a leadership body, we're also looking for folks that want to take that lived experience and learn and make things better for people coming after them. That's the biggest distinction. I see a question. Is there a word limit for each question? There is no word limit. Um, each question will tell you about like what target length you should have, so that you don't feel the need to write too much. If you need to express yourself in a longer answer, feel free. If you can express yourself in a shorter answer, feel free. Um, the first circles meeting is going to be decided with each individual circle. We would like to have that first meeting be in October, but when exactly which week, we will decide that with each individual circle. Most likely, circle meetings for collective will and Francophone will be Wednesdays. So Wednesday late afternoon and evenings. I share that because we try our best to make our meeting times as accessible as possible. But we are also staff with lives outside of this work. So I do want to manage expectations and say that we can't host meetings every single night of every single week. So there will be some container around, like, okay, we'll do them late afternoon or early evening, and maybe it's between Wednesdays and Thursdays, but Mondays, Tuesdays, and Fridays are off. We need staff, obviously, to help manage and run these meetings. So it's going to be about like an agreement that we come to with the circle members. Uh, for how long the circles run, each term of the new members will be for 1 year, and it's renewable. So you'll sign on for a 1 year term, and then later on, about 9 months into your term, we'll check in with folks about either renewing or recruiting for new members as well. Again, if folks don't want to renew. We have had people actually in the past iterations of DAC, we've tinkered with different lengths of terms, and just have found that life happens. So it's best to give people the option at 1 year, because priorities change. All right. How many new positions? It's 15 circle members per circle, up to 15. So we're actually recruiting for almost 40 people. So there's lots of opportunity. There's folks coming back, but there's also lots of opportunity for new voices and experiences of all kinds of experiences. Um, we have people in the network that have type 1, type 2, MODY diabetes, LADA diabetes, pre-diabetes. We have folks that have had their pancreases removed, and that's why they're part of the network. We have folks that have had chemotherapy-induced diabetes. There are no experiences that are turned away. If you are connected to diabetes with your lived experience, we welcome you into the network. That also means we want that reflected in our leadership circles as well. Um, awesome. All right. So I'm just keeping up here. Do the circles inform the fellowship? The circles actually co-designed the entire fellowship with us. Uh, Basically what happened is that I had the idea for the fellowship several years ago and brought it to the circles, including like Matt Larson's on the screen right now. He was part of those meetings of like, hey, we want to run it. Oh, Janice too. Um, but Janice is saying hi to Matt. I understood now. We brought it to the circle and said, we have this idea. We want to do a fellowship. What's important to you as a community and leaders in this community to be part of this. So Circle members literally helped us design the application, the questions, what's evaluated, what's important. Things like having a conference at the beginning and at the end of the fellowship are important, and that became a core tenet of the projects. Um, so Circles also helped us design our like patient partner recruitment form on our website. They helped us design how we send invitations out to our mail list. Um, yes, lay language is important, but what else is important to people? Um, Helped us design minimum requirements on what patient partners need researchers to fill out when they recruit for folks. Uh, I'll also transparently say, please feel free to raise your hands and ask your questions unmuted because I also am doing my best to keep up with the chat, but would love to hear your voices if you are able. That also makes it accessible for me as a human being. Um, Word limit for, yeah, I also saw a question about discussing Loop and other DIY systems. I'm not sure what that question entails. So, Victoria, if you're welcome to unmute and clarify that question as well. What do you mean by open to discussing Loop and other DIY systems?
Well, I'm personally kind of connected to more of a loop
Yeah,
community.
yeah.
And so that's foregoing a certified system. It's like not regulated. And so I'm wondering, like some endocrinologists were like pushing us away, but now they're more open to like working
Mhm,
with us. So I was
mhm.
wondering on the stance with like official capacity to represent that.
Yeah, to be clear, loop is actually regulated, and Canada was the first country in the world to put loop in medical guidelines to endocrinologists. That happened 3 years ago, and we were a huge part of that advocacy push.
Mhm.
Last year, one of the fellowship projects was dedicated to increasing access to DIY systems. So when it comes to loop, we have no position other than like we need to get access to care to people with diabetes to live better lives. Um, it is not our job as a research network to get people on loop systems, but can we advocate for more research, policy improvements, and tools that increase access? Absolutely, and we're very active in that space. Yeah, lots of loop leaders that are part of the DAC network. Kate Farnsworth is on our steering committee and has been critical in that work for years as well. So, yeah. I think you had another question, Victoria, but I can't remember what it was because the chat. Yeah, go ahead.
Yes, it was like who does get the final say on decisions and like who's above you guys, like who's your boss?
I will first say that final decisions are not made in a hierarchy model. Every single application is reviewed by two people. All the evaluation criteria are published online, so you can see exactly what you're evaluated for before you even write your application. The people who evaluate applications are us, but also alumni, patient partners, other staff at DAC, like operational staff, people from our board, people whose kids have diabetes, basically folks that represent like the diabetes community at large. I will say that reviews are heavily overrepresented by patient partners versus staff. I would say 80% of reviewers are people with lived or loved experience of diabetes. Every single application gets reviewed by two reviewers, and then that gets calculated on the back end based on evaluation criteria that took about 16 months to co-design with people with diabetes. And then we have a meeting with all reviewers to basically see if there's any tiebreakers that need to be made. So it isn't a hierarchical decision. Like the person above me is our executive director, Tracy, and she is one reviewer of 19. So
I
yeah.
didn't really mean for the job, but like just the circle decisions in general.
So if a circle decides to want to do something, you mean?
Yes.
That's a collaborative decision. It really depends because the circle could say that they decide that they want to build an infographic, or they could say that they want to um, go to Australia for a conference. Those decisions are very different. I might not have the budget and capacity to support the entire circle going to Australia. If the circle wants to build a project or a tool, that decision is made collaboratively with us as a patient engagement team. Um, yeah, like it really, every decision depends um, on scope, timeline, and most often, I would say it's very rare that there are black and white, like immediate decisions at the circle level in the sense of it usually, like even the fellowship was not a black and white decision. It took 2 years of discussion with the circles to deliver on creating a fellowship, for example. What we do is every single thing that gets discussed, we close the loop on every discussion, not just what we heard, but what needs to happen. And then if we get feedback, what feedback did we get and what limitations or enablers exist? And then we decide together. Do we abandon it? Do we do something in the middle? Do we get creative? Do we choose another priority? I don't know. It really depends. So another example of that is we have a partner award on our website. We ran that because the circles came to us and said we want a recognition award for patient partners. So then it was like, okay, an award can exist in many different iterations. Let's first, we're going to hear you. We're going to review our budgets and our opportunities. Here's a menu of options, and then we decide together what that looks like. One of the key decisions that came from that is that the circles told us that whoever wins the award wants to be on a panel at a conference. We can't make another organization do that. At that time, we were hosting our own event, so we had a dedicated panel for all the award winners, and they got to choose what they talked about. Matt, not to put attention on you again, Matt was one of those award winners and was part of those conversations around like what even matters to you as winners. So that's what I mean by like it's very, I know gray area is nuanced, but most of our work happens in the gray area. Yeah. Al has a physical hand up. Go for it, Al. Do you want me to unmute you? There you go, friend. Wait. No, you're still muted, but I can tell you're talking.
Yes, that's because I have such a soft and hard to hear voice.
What's up?
So well, one of the questions that came to me as I was listening to you answer other questions and what I think it was Victoria, although I'm terrible with names, so I'm sorry if I'm
No, you got
misremembering,
it.
was just talking about like some ideas about what they're interested in.
Mhm.
Um, is there is there like a backlog agenda already of topics that haven't yet been addressed but that are already in the queue? And is
Mm.
that something that's shared with applicants um, to see if there's something that's already on the docket, or is it every
Good.
year like that gets closed out and it's all dealt with and you start fresh?
Great question. When it comes to things that need to be addressed in diabetes research and policy, the list literally never ends. But that's also why we don't keep a list in the sense of like timing is very important, not just for like timing of the research community, but timing of human beings' lives. So it's also very important to us that when we assemble a circle, we have a conversation together about how we're going to work together and what matters to this circle and how you want to take this directional term. What does leadership look like to this group? Um, we will likely, not likely, it will be a reciprocal relationship where we as an organization come to the circle and say, there's an opportunity. We can, oh, someone's accepting submissions on this paper, or someone's accepting presentations on this, or we got an email with this request. But that will be a conversation. One thing that I know for sure is a priority is the town halls, and that's why that's on the webinar. And we're sharing that very transparently because that's been something that we've talked about for 2.5 years, and it's time to deliver on it. So we want the new circles to take lead on that, of like, how can we make that happen? Um, so that's one thing.
Can I ask a? It's not quite a follow up
Yeah,
question,
absolutely.
but it's just another question that I have. Um, to be a member of the Francophone circle, for instance,
Yeah.
or or the one that I guess is the allophone circle because it's not specifically tied to a language. Does it require having it as your mother tongue, or does it just
No.
require a degree of fluency?
Exactly. And the application also asks just, are you comfortable in having meetings in French? Also, we recognize, same with English, like it's A, are you comfortable to communicate and you decide what comfortable means for you? And B, it's about like an identity question as well. We have lots of folks that are Francophone patient partners that have never stepped foot in Quebec. I
Well,
like,
that's because Ontario, New Brunswick, and many other
sure,
provinces have huge
Manitoba.
francophone
Yeah.
populations. Yeah,
We also have lots of newcomers and immigrants to Canada that come from Francophone colonies. So that's a huge part of our
absolutely.
community. So that's why we don't ask, the application won't ask you for level of fluency in written or spoken any language. We just trust that you evaluate your level of comfort and how you feel most confident. If you feel most confident in French, check that off. If you feel most confident in English, check that off. It also gives you the option to select multiple circles. So if you are a wizard and you feel most confident in all of the things, check them all. And that also provides our reviewers some flexibility of like, if someone is eligible for more than one circle, we will try to fit you in where we can. We try our best.
All right, thank you for that clarification.
Of course. Thank you, Al, for your podcast voice.
You're very welcome.
Yeah. Any other questions or comments from the group?
I have another one.
Go for it.
Can you give more detail about the Indigenous Circle and like kind of what that would involve?
Yeah, absolutely. So the Indigenous Circle is for folks that are Indigenous and have a connection to diabetes. That's co-run with an Indigenous partner organization called Indigenous Diabetes Health Circle. The work involves exactly like scope-wise similar conversations as a collective or a francophone circle, but for them, um, we don't predetermine the agenda. It's self-determination is a huge part of the Indigenous patient circle. Um, and also, like similar to the Francophone circle about talking about Francophone priorities, not just for Francophone communities, but for the country at large. Similar for the IPC of like how do we indigenize our work as a network, as well as what are the priorities for Indigenous patient partners.
Okay, so I personally don't have any like heritage
Mhm,
or straight connection, but my studies have led me to learn a lot
mhm,
and like continue to grow, learn, and becoming more a part of that. Is that
mhm.
like eligible in a way?
No. The Indigenous Patient Circle is only for folks that are Indigenous or have Indigenous heritage. It will ask you for self-identification. We absolutely like learning about indigeneity and how it intersects with diabetes, especially, is a huge part of everybody's work at DEC. But this is a reserved space for folks that are Indigenous. Yeah. Lots of great questions in this group today. All right. I'll do a last call out for any other questions, comments. I know I'll just say verbally for the recording, because sometimes we have people ask about age. There is no age cap, and if you have a SIN number and you are able to be paid, which usually is around 15 or 16 years of age, um, then you're eligible. So we have patient partners in their 80s, and we have patient partners graduating high school. So there is no age cap. And the last thing I will say is, um, we know, and like I know also from personal lived experience that in diabetes communities, we see type wars, like this type is harder than that type. Why don't you have a type 2 circle versus a type 1 circle versus a LADA circle? I want to very explicitly say that that is something that you won't see DAC do very intentionally because we are here to learn from each other, but also learn about ourselves and some internalized feelings that we might have that we don't even realize. For us, there is no such thing as a harder type of diabetes or an easier type of diabetes. There are no exclusive spaces for a certain type of diabetes because we are one community and we want to learn from each other. That also means learning about why do we feel the need to defend a certain type or a certain management style. You will never see us say, for example, pumps are an easier way to manage diabetes. We have folks that have had type 1 diabetes for decades and are still on injections and shots. All the power to them. We want to know about how we can make their quality of life better without forcing them to do something else. The same thing goes for type 2 and any other type in between. We are not here to tell anyone what the right way to manage their diabetes is. We're here to work with circles to make research and policy spaces safer and better for our community and to make them reflect our needs better. And that means needs of everyone and all management and diabetes types. The other thing I will say to wrap us up here is that someone who was diagnosed with diabetes a week ago will have the same evaluation as someone who's had it for 45 years. And you'll see that in the way that we evaluate applications. Your diabetes experience is your diabetes experience, and we cannot compare that to anybody else's. What's important for these circles and what we want to see in your application is what do you want to do with that experience to make it easier for the other folks coming behind you? And you don't need to have diabetes for 50 years to do that. If you've had diabetes for 50 years, I commend you and I salute you and I want to be you one day because I want to live as long as I possibly can with my diabetes. But my experience is not more important than yours and vice versa. No matter how long you've had diabetes, it's valid in this space. And I'll answer that last question, research versus policy, which one's weighted more? To be honest, there's no answer to that because every research project in my ideal world should be informing policy and should be designed to feed into policy from the beginning. Do I guarantee you that that's what will happen? No, I cannot guarantee you that. But that's what we're going to try to do. And for every researcher that comes to our desk and says, we want to recruit patient partners, we say, cool story, bro, but paying them isn't enough. What are we going to do with that information? How do we make it accessible to everybody else? How do we improve the pump access program? How do we get needles covered? How do we, etc. So, yeah. Research is imperfect, policy is even more imperfect, and people are even more imperfect. So we're just trying to do better in an imperfect system.
One last question.
Sure.
You said this was Canada-wide, so like province
Yep.
to province, you work with all of the policies.
All of the provinces and all of the territories are represented in our network.
Cool.
Yeah. All right, we're gonna stay on for a few more minutes. We'll wrap the recording now. And thank you again for your time, your attention. Life is very busy, and diabetes makes it even busier. So we really appreciate your presence. We really encourage you to apply. You'll get a follow-up with these recordings, and they'll be on our YouTube. And the one thing I ask of you is to live out the principles of the circles. If you're applying, send it to someone else as well. One thing that we really, really don't condone or promote is gatekeeping of opportunities. So if you're thinking of applying, share it with a friend as well, because there's room for everybody. And even if folks don't end up on the circle this time around, there's other opportunities. So please share it with someone that maybe has never heard about patient partnership before, or maybe has. You never know, and you never know whose life you're going to change. And thank you so much. Again, take care, folks.